This
John,
conference will now be recorded.
we need to give Herb some time too.
Yep, definitely. We all are eager to catch up with that. Okay, this is I'm John, and this is the ANCAN high risk recurrent um, meeting. It is the 20th of March, and we want to start by acknowledging some of the sponsors that make this possible. We have a phrase in medicine that's called TNTC, which means too numerous to count. And our sponsors have gotten too numerous to count now. Oh, Ben, let's see. Ben has just rescued me. Thank you, Bayer, Pfizer, Myovant, Janssen, Myriad, Telix, Foundation Medicine, and that's it. Now,
Yeah.
let's start off as we usually do, welcoming our new man, Joseph. Joe, how old are you?
75.
Where do you live?
Philadelphia area.
Okay. Do you like to be called Joe, Joseph? What?
Oh, it's fine.
Joe?
Mm-hmm.
Okay. Um, tell us when you first were diagnosed with prostate cancer.
Back in 2013, and
2013. 10
yeah,
years.
yeah, and well, I guess maybe almost 10 years at this point.
Just okay.
I've had a prostatectomy. Then a few years later, I had radiation of the prostate bed, and then 2 years ago, I had a kind of targeted radiation outside the prostate bed, and
How far outside?
it was a little hard for me to say. A hip, maybe,
Okay.
somewhere over there. Um, at the moment, I have a what do you call it? PSA reading of 1.01, which I know sounds like peanuts, and I kind of thought it was too in a way.
Well, it
Uh,
all depends on what came before, so
yeah.
tell us about that.
What do you mean by that?
Well, your PSA is 1.01 now.
Right.
Now, when you had your original radical prostatectomy, it was up there somewhere. Where was it?
For something, I think. I'll have to look.
And
Um,
then, and then it
no,
must have gone down.
it had reached 5.5, something like that, 5.4.
Okay.
So that was
And then
July
it must have gone down
2013.
to zero for a while because you didn't have your
Right,
salvage radiation for years.
right. That took place in December and January 2017, 2018. So it was like 4 years later.
Okay. So you were monitoring closely. It popped up, so you went in and radiated the prostate bed.
Right,
And then it must have gone back to non-detectable again because you didn't have treatment for a couple more years.
right, right.
Good. Okay.
And yeah.
And then how did they find this metastasis in your hip or wherever it
Um,
is?
they gave me an Axiom PET scan, and
Okay.
it was probably the third one I'd had over the years, and nothing ever showed up until that third time, and
Okay.
then they found something they could shoot, I guess.
Yeah. So they shot at that and your PSA has stabilized at 1.01 or is falling or
No,
rising or what?
it's always going back up. It sort of disappears and then it gets whacked back. In fact, one of my doctors calls it whack-a-mole. What we're doing.
Yeah, we
It
understand
disappears.
what that
It goes
means.
way down and then it starts working its way back up.
Yeah.
I think it's fairly slowly. It's not doubling at this point, at least. It's not doubling in 6 months, which is another indicator, right?
Right.
Uh, so that's where we're at. So most recently, uh, I had a test in February and of this year, and I expected my doctor to say, "Well, we'll just keep our eye on it." And he instead said, "I think you should go for hormone therapy." So that kind of set things off for me. I ended up talking to a medical oncologist at Fox Chase Friday, this past Friday, and she's of a different opinion. Um, and I've gone to her before, so I trust her quite a bit. Um, what she would like to do is have uh, another PSA test in 3 months, which would be early to mid May. Probably also have a, what is it called? PSMA
Yep.
scan, PET scan, and then see if there's anything to whack at, or whether we
Yeah.
have to do something more serious. So that's kind of where we're at. And I was probably in panic. Uh, After talking to her, I was reassured, to tell you the truth. Uh, but in panic, I decided to talk to a bunch of people. So that's how I got involved with you guys.
Oh, perfect timing. Every one of us knows what that panic is like. Excuse me. When one of the factors is what kind of Gleason scores did they come up with when you had that radical prostatectomy?
4+3. This was back in 2013.
Right. And you haven't had any tissue removed since then, so that's basically what it is as far as we know, right?
Um,
No
well,
further
there's no
biopsy.
prostate to measure it on, right? Oh, no, I
Yeah,
guess
I
we could
mean,
measure it on other tissue too, right?
well, no, you really can't. Once the prostate is gone, there are uh, there are ways to sample the blood for genetics, though. Have you ever had any genetics test?
No,
Okay. And
that's a way of telling how rapidly it might grow or something like that.
yes, it can be a predictor both of what's provoking your cancer and a predictor of what drugs might be best chosen for treating your cancer.
Hmm.
So many of us, if not all of us on this call, have had the genes tested that we inherit from our parents, and also the genes in the cancer itself tested, because that can mutate and start off the cancer process. So when the time comes to make treatment decisions or predict the course of the disease, that's another factor like the PSA and the
Hmm.
PSMA and the doubling time and all the things you mentioned to help guide treatment. And the last question is, who's treating you?
Um, I've gravitated from Jefferson Hospital, which is one of the Abington Jefferson Hospital, which is one of the major hospitals in Philadelphia, toward Fox Chase, which is another major hospital in Philadelphia, which is cancer only. Um,
And what oncologist or who did they assign you to do your quarterback your treatment?
I don't know that I have well, I guess my urologist is my quarterback, if you want to say that. Um, my original urologist was the one who actually did the operation on me, the prostatectomy, and I would still be with him, except that he switched practices, and I thought, well, let's give the new guy a chance. I probably should have gone with followed the original guy. In any case, I'm with a different urologist and have been for maybe 5 years, something like that. But my radiation was also done at Abington Jefferson Hospital, and now I'm working with people at Fox Chase. That was always a consideration, and I went for interviews or whatever you want to call them before I did anything. I always sort of went back and forth between those two, and I've decided to go with the Fox Chase. So I have a medical oncologist who, I don't know, maybe she's my second quarterback. I'm not sure how you're using the term. But I go to her, and she generally hasn't been pushing medical solutions. She's had me look into the possibility of further x-rays. Or not x-rays, radiation. Does that make any sense? I'm not sure what you're asking.
And who is she exactly?
Her name is Pooja Gatalia. Gatalia. She's an Indian woman.
And is she a GU med-onc?
Is she a what?
Does she have it? Does she have her specialty in GU medical oncology?
I don't honestly know. I assume she did. I assume she has
We
a
need to look her
specialty
up.
with urology, but I need to find that out, I guess.
Can you spell her name?
Gatalia. And she's a Fox
Okay.
Chase.
She looks like a GU med-onc to me.
Does she?
Yep. Hematology, prostate cancer, bladder cancer, testicular cancer. Yep. Department
She
of
seems
hematology.
very knowledgeable. I've been very impressed with her.
Yeah.
Okay. Thanks, David. So your situation now is you've gotten a couple of 2 or 3 whack-a-mole treatments. Your first 2 were very effective in knocking out your prostate cancer for a couple of years. It eventually snuck back both times. Now it's raising its head again. It's up to 1.0. You are very upset about it because every time it goes away, you hope it'll stay away, but it came back yet again. And now you're kind of in a spot where you and your oncologist are debating what to do next. And
Yeah,
rather
that's
than go immediately to ADT, you've decided to wait a little bit and recheck the PSA and the PSMA PET scan.
that's pretty fair as a summary. The only thing I would quibble with is that uh, if they presented to me the option of hormone therapy today or in 3 months, um, I would think hard about whether I did it at all, which may be crazy. So that's part of why I wanted to talk to other people. I'm very reluctant to do that for maybe lots of
Because
reasons.
of all the side effects you've heard about.
Certainly all the side effects and the fact that I'm actually today in pretty good shape. It's not like I'm falling apart, um, where all those side effects might not bother me so much if that were the case. And at some point, I may not have a lot of choice if I want to live. I'm not sure. But anyway, that's the dilemma for me.
Okay.
How
So the
old are
fact
you?
that I don't have to face that for at least 3 months is good.
He's
Can I
75, David.
can I make a comment about the hormone therapy?
Sure.
Um, when I first started my hormone therapy, I was on bicalutamide, and it knocked my PSA down for almost 5 years, and I had zero side effects from the bicalutamide.
Wow.
Once the little buggers got used to the bicalutamide, I went to enzalutamide, and I did have some not terrible but not so good side effects from that. So there's different ADTs, and you don't want to just dismiss ADT in general,
Okay.
because it's pretty obvious that different ones may or may not produce side effects.
Did you have to play around a little bit before you settled on the good one for you? Or did you just
No,
start out with it?
bicalutamide was the very first one that they my urologist prescribed after the recurrence after my prostatectomy.
Yeah. So
And like I
I
said, that
think
that 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 kept everything well down into the point 0.1, 0.2 range for nearly 5 years.
Mhm.
I think you're probably beyond that point, Joseph. I mean, it would be
Could be.
nice to think that was an option for you, but I'm not sure it is. I mean, I've been looking today, was watching a webinar, and where we are today with a diagnosis like yours, and with what we know, is that the appropriate treatment, especially from a center of excellence like Fox Chase, is probably going to include two uh, agents, an LHRH drug and a second drug. And the difference for somebody like you in life expectancy from certainly versus the ADT is about 4.5 years benefit. And if you do nothing, the difference is probably going to be quite a bit more than 4.5 years. It might be as much as 6.5 or 7 years. And the problem is that this disease is largely asymptomatic and we feel great. And then when it decides that it wants to wander off into some far off place like your hip, it has to be treated. And as much as we don't necessarily see that because we feel great and we don't want to treat it, we know that if we don't treat it, your life expectancy is going to be pretty short. And by the time you're ready to treat it, there isn't enough that we can do. But if we treat it now and early, the evidence, and we have a lot of that evidence, suggests that you we can get you a long time. You can manage this disease for a long time. So nobody wants to do hormone therapy. We get that. No one.
Right.
It's not pleasant. It's kind of like slow drip chemotherapy, but we know it makes an enormous, enormous amount of difference. I'm not really sure why Dr. Catalia would want to wait 3 months, other than your reluctance to go on it, which she's hearing, so she just doesn't want to push the issue right now. But I, we're not medical docs, but I mean, we can't give medical advice, but I don't see where she's going with this, because the best that can happen is she finds something else to shoot at. But this is a game of whack-a-mole, as you say. And so there has to be some systemic treatment. And the longer you defer that systemic treatment, the more the disease is going to get a grip. So, I think there are some guys on this call who have been through what you're going through. And they need to share that with you. We have a little bit more time, but I'd love for some of these guys who are on the call, especially anybody who decided to defer the hormone therapy, to talk to you. I see a couple of hands up, so let maybe start with David Musling, who is a very sensible voice amongst us all.
Thanks, Rick. Well, Joe, I was shitting in my pants and I wasn't doing hormone therapy because I just heard it was bad. And it turned out, for me, it turned out to be a big mistake. Um, my PSA went up after I didn't do the hormone therapy. I did radiation, but I didn't do the hormone therapy. And had I done them together, I would have been able to jump on my disease much quicker. And it turned out the hormone therapy is not that bad. I was on it for 24 months. I'm off of it now, and I'm clean. I'm on a single dose, uh, just a pill therapy right now, and I'm doing great. But I could have saved myself a lot of headache if I did it. The fact that you're in good shape and that you sound so strong and look so strong, you'll be fine. It's all, a lot of us are all have been on it. It's not that, I mean, it's not that terrible, especially if you eat well and you exercise well and take care of yourself. You'll be okay. And like like Rick said, it's you can live with this disease for many years if you deal with it today.
Jim Marshall?
Yes, anyway, I have been on the ADT plus a second level drug and abiraterone for 5 years. Okay, and it sounded horrible, except the thing I found out very early on: if you aerobic exercise, and I generally happen to jump on a bike generally every day or so. Okay, I am extremely active, all that stuff. I didn't find the side effects that bad, except at the time I got tired. The hardest thing I had to do was to say, I need to go exercise, because the thing, and where the body says you should rest, because if you rest, you shall not be tired, but that's
Right.
wrong.
Right.
And so, as I said, actually, for the first 3 months, I didn't have things except for the hot flashes, which there is a device and way to curb those, until I could not exercise for about 4 days. Okay. And boy, it was miserable. I finally happened to get out. I stayed active, and I have been active for the last 5.5 years. I am currently on a treatment holiday now. And so eventually I will go back on, and I don't find it that it has stopped me at all. Slowed me down because of age. Well, almost 79, but I'm still active, very active. And hey, it's a blessing.
Thank you, Jim. Let me get a couple of more comments, and then we might have to start moving on. Alan Moskowitz?
Yeah, I'll just briefly mention I was on hormone therapy twice, once for 6 months, concurrent with radiation about 7 years ago. And it wasn't any big deal, really. I mean, occasional hot flash, but I didn't have much in the way of side effects, given that it was only 6 months. I had a whole year of ADT. I had the Lupron along with enzalutamide for the better part of 2022, and it was manageable. And along with that, I also was anemic due to some blood loss, and so I did have fatigue, but it was still very manageable, and I didn't hesitate for 1 second to not get ADT. My PSA had come back after those two therapies, and yeah, I was told by more than one oncologist to basically hit it hard, and hope for a longer term remission. Right now, even after having no treatment for a little over 3 months, my PSA is still undetectable. So I certainly wish you good luck if you go that route.
Thank you. And Gaushan, did you have anything?
Yeah, I just wanted to say that in 2019, I had reoccurrence come back after I had my prostate removed in 2013. And then my GU Medoc, we immediately went on December 1st, 2020. I had my first injection of Eligard. And several months later, I started 30 sessions of radiation. And I continued the Eligard injections for 30 months. And I recently went off of that, and my last PSA test was undetectable. In Panama, where I also get checked, they go down 3 digits, but 0.000. I didn't really have any side effects. I never, fortunately, had any hot flashes. Just like some of the other guys said, working out and keeping active and exercise and pushing yourself when you're a bit tired to do a little bit more or go out that day was helpful. So for me, it was the right thing at the time. It was the right thing to do to combine the two together. And right now, I'm having good results. We'll see as time progresses while I'm on the holiday. But I wouldn't, truthfully, I wouldn't be afraid. But each person has their own situation to evaluate.
So, Joe, if you stick with us, we will talk you through the management of medications if you and your doctor do decide to go on them. Many of us kind of have a feeling that you will, but we don't know for sure what you'll decide. But the message is that we'll support you through it, and that it's manageable.
Mhm.
Now, just to give you a little orientation to our group, we meet on the first and third Mondays at 8 o'clock Philadelphia time. You're on Eastern time, right,
Right,
Philadelphia?
right.
And on the second and fourth Tuesdays at 6 o'clock Philadelphia time, what you see before you is, as you know already, people who have experienced recurrence, like you have. There's a lot of experience here. There's a handful of people who are moderators, and everybody else is a regular attendee, and everybody's really welcome to contribute and support each other. So we welcome you and hope you come back. There's a little thing up at the top of your screen that looks like a speech bubble on a cartoon, except it's square, and
The
that's our
chat?
chat.
Yeah.
So while you're listening, while you're watching, and if you want to make any comments or ask any questions, you can always put them in there. You can send your questions to everybody or just a particular person. Okay?
Okay. One quick question, then I am done. I had trouble figuring out whether I should come to this group or to the active surveillance group. And this one is earlier in the week, so I came here first.
I think this
Do
is your
you have any
group
thoughts on
now.
that?
Yeah, I think this would be your group now. Rick
Okay.
will confirm that one way or
Yeah.
another because you have recurrence.
Okay.
Yeah, active surveillance, the active surveillance group, and we try to stress the message, certainly in the reminders and on the website. I don't know if you looked on the website, Joseph, but the active surveillance group is only for early low risk. It's for men with 3+3 or 3+4 disease who are deciding whether to enter treatment. It's
Okay.
not late, it's not recurrent active surveillance.
Okay.
So this is definitely the right group for you, and you'll get the reminder. I think you might have already gotten this reminder, And we've got a bunch of guys in even on this call, we've got a bunch of guys in your area, and I'm sure they're accessible other than Joe. And we just encourage you to keep coming back, and you'll hear more and more. We just want you to keep this disease under control and where it is right now. That is the name of the game.
Thank you very much.
Joe, after we introduce the new guys, we go down to anyone that wants to bring things up. So I'm going to start going down the list of other fellows now. I got about 10 or 11, so please bear time in mind. Alan Moskowitz, you're first.
Hey, just a quick update on sort of where I've been. As some of you may remember, I had prostatectomy just about exactly 10 years ago. It recurred, had to have radiation along with ADT, as I mentioned a moment ago. And then PSA kept going up. And anyway, last year I started hormone therapy, Enza and Upron. But in my case, the big problem was radiation cystitis. I've commented on that maybe once or twice. This was really bad, bleeding, very bad bleeding with clots, blockage in the urinary stream, hospitalization, total of 5 times, once a month, basically ending this past January. Luckily, I ran across through a consult at the hospital, got a good urologist, better than the ones I was using, and he recommended putting in what's called a suprapubic tube, basically a tube that runs from the bladder directly out from through your skin. And the idea is if I got clots, they'd be easily passed as opposed through the urethra. And that really was a lifesaver. I still have that tube. And he recommended at least 40 treatments of the hyperbaric oxygen therapy, which I started earlier this year. I had 20 last year, but unfortunately, due to bad advice, not only from 2 different urologists, but also the doctor in charge of the hyperbaric center, they all said I needed either no treatment, no rush to treatment, or only 20 treatments. Well, 2 newer urologists said 20 is never enough. You needed at least 40, and you basically have to start over, which I did. And then they recommended I go to 50. And so let me tell you, 50 treatments, 5 days a week, every morning for 2.25 hours in that chamber. It's a real slog. I mean, it feels like going to work and then some. Fortunately, number one, I only have 6 more to go. So it feels like the light is at the end of the tunnel. And most importantly and miraculously, it has basically eliminated my problem. Occasionally, I get once a week, I get a little bit of a tinge of blood for 10 minutes, but the doctor says that's primarily due to the suprapubic tube rubbing against the inside of the bladder. And I say it's nothing short of miraculous. I feel like I have no risk of going back in the hospital. Minimal, I'll say. I'll never say zero. I mean, there is always a chance of recurrence, but I'm told and what I've read, I won't have a problem. And so I did have my first blood test, as I alluded to before, just last week. And PSA still undetectable. Everything else is pretty good. But because my iron levels were low, and obviously the hemoglobin and hematocrit and associated parameters, I asked my internist to give me an iron infusion. Just taking iron every day, forgetting the potential constipation, will take forever to build up what I lost through multiple losses of blood. And he was reluctant. So I begged my oncologist. I said, listen, I got to have an iron infusion. I said, I'm never going to build back muscle. I'm never going to get better. I said, I've got to have it. And so he said, okay. And I had 5 transfusions, 1 a week with iron. And That was through Sloan Kettering. Had it done locally in New Jersey, and unfortunately now my levels are pretty good. I'm gonna push my oncologist for a couple of more infusions this week, and if I get them, great. If not, I'll just take iron. So I consider myself lucky, but I'll tell you that it's been quite an ordeal. I still got to get back to normal urination. I had taken Botox a few times, overactive bladder, which I think actually was due to the onset of radiation cystitis. Nobody connected that, but I think that's probably the situation. So I've still got to get back to that. So there's a few more things left to get back to normal. But right now, I'm just focusing on getting those hyperbaric treatments done. So that's my story. It's I know we've had some other people on with this condition. I talked to someone offline about it. It's really nasty. In many ways, you know, the cancer is more manageable. Even with fatigue, even with the hormone therapy, I would choose that before I take radiation cystitis, without a doubt.
It sure sounds like it was miserable, and I guess the message is if you're going to do hyperbarics, really go for the full dose, isn't it?
You do. You need 40. The maximum is considered 60, at any given period of time. They didn't count the 20 I had last year because that was back in August. If I need another 10, the next several months, fine. But otherwise, I should be pretty good. Once it goes away, you're pretty well set. But I am afraid to ride a bike yet. I don't want to do things that might, trigger it. I got to be careful. I mean, you all know that taking, things like ibuprofen and all, or tend to be, cause potential bleeding and all. So, I've been extremely reluctant to do anything that could trigger another bout. And I'm willing to put up with back pain, leg pain, foot pain, and take Tylenol, but not anything else. Anyway, that's the story.
Phew. Comments?
Any chance that they will be able to remove the catheter, Alan?
Well, yeah. So that's the real challenge, Rick. So the catheter, it isn't. I mean, again, it's coming through the skin. It goes into a urine bag during the day, which isn't really a hassle. And at night, I use a big overnight bag, which many of you, or if not all of you, are familiar with, which is sort of nice. I don't have to wake up to go to the bathroom. Okay. But the goal is at some point to take it out. This is a very easily reversible operation. I mean, they just pull it out. Putting it in was a 15-minute outpatient procedure. And so the goal is to take it out. And I basically, the step one is, can I hold urine comfortably in my bladder, plug the catheter, and then, let it out normally, hopefully. Or if not, then use the tube for a period of time, get the bladder adjusted again. And then hopefully once I can go through the urethra and all, then we'll take it out. If I can't go, and it may take a while before that bladder returns to normal, well, then I'll just keep the catheter and just avoid using the urine bag. So it's going to be a stepwise process. And even though that, could come around with incontinence, because I've stopped doing Kegels for the moment. I got to start it up again. I don't know how that sphincter is going to be after being not used for 3.5 months. I don't really know. And so eventually, Rick, the answer is yes, I'd like it out, but at the same time, I'm not in a big rush. I sort of have to wait and see.
So this is a perfect segue. I wasn't planning on this, but this is a perfect segue to the notice that I just put in the chat window, which George pointed out. I had an error in the date. It should be 329, and I had a typo there. It says 339, but obviously there's no 339. It's 329. I'll correct that when I can. We have our superstar doc, who many of you have seen and who I know a lot of you really like, Dr. Rachel Rubin, who's on our advisory board. She has selected a very attractive doctor of physical therapy, Tracy Sher, who she works with. And on the 29th, a week on Wednesday, they're going to be talking to us about pelvic floor rehabilitation, which is what you're facing, Alan, and the benefit of using a pelvic floor physical therapist that some of us in the group, not myself, but others in this group have used. And there are huge benefits. And this is not only for incontinence, but it's also for ED. And I can almost guarantee that this will be a very entertaining and useful and beneficial webinar. So the link is in there. Please sign up. I'm going to correct the date right here because Mark sent me through, I think, a way to do it. Hopefully this works. Let's just see. Yes, that's right. So there you go. So, and we'll post it in again a little bit later. Mr. Gallo is usually on top of, Captain Gallo is usually on top of reposting stuff, so maybe he'll get to repost it later. But we'll put it in again.
And if you do click on the link that you listed in the chat, it will properly register you for the 29th.
Right. And this will be going out in the reminder next week. It'll be going out as a separate webinar notice. Tell your friends, it's free, it's drop-in, and it's guaranteed to be entertaining. Dr. John is one of the moderators, and the other is one of our MS lead moderator, Kim Stroh, who's just wild and crazy, and she's fantastic. And she's already worked with Dr. Rachel before. So there's going to be lots of great information, it'll be fun, and it'll be very informative.
Rick, one minor change there. A webinar requires you to register.
Right. Yeah, no, I didn't say it was free and drop-in. You have to register. Quite right.
Yeah, you said drop in, and that's totally different. I know what you meant. I just want to make sure everybody else did.
Okay, thank you, Rick, and thank you also for writing today's invitation. Hey, Pat Martin, you ready?
Get my microphone turned on. Just a real quick update. I've been doing a study drug since the first of the year. Every 3 weeks, I go up and get an infusion of docetaxel, and I'm on a capaversitib out of AstraZeneca study drug. I take 8 pills a day, 4 different days, Saturday, Sunday, Monday, Tuesday, 2 a day, and they kind of knock the props out from underneath me. Anyway, I've gone up. I go up and I get my blood checked every 3 weeks. 3 weeks ago, it was 10. The PSA was 10. This week, it was 11.72. So it went up 11%. And I think they're waiting to see. I'll have some scans in the middle of April, and then they'll determine how far I go on the test and see what else is available to me. Doesn't seem to be, my PSA has not been affected. It's gone logarithmic on me, and not a pretty chart.
Is there a placebo group in this study? Is this a blind study or an open study?
It's a double blind. So there's a 50% possibility that I'm getting a placebo. My oncologist, he figures there's 90% that I'm getting the real thing because of the side effects that I'm suffering. And
Yeah.
I'd put it at the same. Um, Anybody that would design a placebo with this many side effects needs to be given this drug. So
Thank you. Keep
no,
us
that's
informed.
What was the marker you mentioned that went up 10%, Pat?
PSA.
PSA. It went from 10.0 to 11.7.
Okay, but when you said it went sky high, I thought it was PSA, but then you were talking about sky high, so
It just went logarithmic. It had been going along on the flat curve, and now it's turned up a definite uptrend. So yeah,
Okay,
growing at
very.
about a little bit less than 12% in 3 weeks.
Pat, could you put
anybody?
the name of the drug in the chat window?
Yeah, I'll do that. It's capaversitib, and we talked about this trial. Anybody here have any questions about Pat's trial experience? Okay,
Perfect.
that's good.
No
Now,
questions, but a lot of interest.
how are you? I mean, do you think you can get through all 6 docetaxel treatments on this, Pat?
I think the docetaxel, I don't have any side effects, I don't believe, from that. They took me off the cappy for 2 weeks because I was reacting very severe to it, along the lines of Alan with peeing blood, clots in and out of the
Mhm.
ER. So they took me off the cappy, get me away from that, and I didn't have any side effects from the dosi. In fact, he said that I could go up instead of just 6 um, doses of docetaxel, I can go out to 10 or maybe even more. And if it's effective, I wouldn't mind doing that. Um, we'll see what the radiographic progression shows in April.
So when they took you off the capaversitib, did those side effects resolve?
Yeah, they did.
Well, I would have to agree. You're probably
There it is.
you're,
Yeah.
you're probably not in the control group then.
I'm not in the control group. I was the first one to enter into the group, and I think they were excited about having a warm body giving them pills back in England from AstraZeneca.
Hmm.
So I think that played into it.
Hmm.
I'm going to move on
Yeah,
to Mark Thompson.
Hi everybody, how you doing?
Hi.
Thank you for having just an update. And Rick and Herb, I'm sorry you're in the hospital again. And but I ended up getting through I had a double hernia for my prostate cancer surgery back in 2014, but then I just back this January ended up having a double hernia from that incision, which was probably one of the most painful things I've ever experienced in my life. They ended up had to put mesh into it. It was basically strangulating the intestines. So I was pretty much in a lot of pain. Rick hooked me up with a couple guys that also experienced that type of surgery. And then I just met with Dr. Anton Arakis. And after 10 years of being on Lupron, he's going to let me take a break from that. So I just had my first blood work results from not being on Lupron for about, I guess it's now been about 3 months. So I'm grateful for that, but I thought my energy level would come back. But it's still been extreme fatigue and definitely walking but I had to learn to like walk all over again because that surgery really set me back. So I was in extreme pain, but I'm very grateful for this group and for the organizers, especially Rick and all the moderators. I really, because I listen to a lot of the recorded groups, and so I hear you guys talking. I don't know what people look like, but I hear you guys talking, and it just gives me hope because I was 47 with stage 4 bone metastasis, so I've been on, done everything pretty much. And so I'm grateful that I'm able to take a little vacation and just to, wait and see. So I do get squirrely in the head sometimes thinking that, now every 3 months I've got to check, and Dr. Antonarakis is suggesting that if my numbers change, he wants me to come right out to Minneapolis immediately. And then he said my treatment would change. But I'm grateful that you guys have been doing it a lot longer than I have. So I'm just grateful that I can listen in and you guys give me hope to keep on doing what I'm supposed to be doing and not to give up. Thank you.
No. So
Well,
what I'd like to ask the group, if I can, for those of you who have done intermittent, and there's a few of you who are on intermittent, have done intermittent, can you give Mark any guidance now that he's off? Because it doesn't happen right away, Mark. I forget how. Share with us again how old you are. 50 something.
I'm 57 now, so it's been 10 years.
Okay, so you're 57 now. Anybody have any pearls of wisdom once you go onto a drug holiday?
How often do you do your blood tests, Mark?
Every 3 months and scans every year.
I would, if it was me, and it has been me, I would go to monthly. Antonarakis would probably be glad to give you a standing order to do monthly tests, and just keep an eye on it, because if you start seeing a pattern of doubling even at low numbers, it might be time to do a PSMA scan or something like that. Just keep an eye on it. That was my history. I went off and I just watched it real carefully, and every time it started doubling within 2 months or so, I acted on it.
Thank you. And Dr. Antonarakis, said if right now it's still less than 0.1, the PSA. So he's suggesting if it even goes to 0.2, he wants me to have that PSMA scan at Hopkins. He doesn't want me to let go Dr. Denmead. So now I have 3 oncologists, Dr. Maricula here at the Tunnel Cancer Center in Delaware, and then Dr. Denmead at Hopkins. And then I also have Dr. Antonarakis there at Masonic Cancer Center in Minneapolis.
I also have 3 medical oncologists, and Antonarakis is one of mine as well.
Now, who was the guy that you guys were mentioning last week about the guy for second opinions for your pathology report that's at Hopkins? Do you remember, Peter?
Epstein.
That's it. Yeah, thank
Jonathan
you.
Epstein. Yeah.
Also, I would
Mark.
add that. Oh, go ahead, Jim.
Mark, be sure that that they include a testosterone test essentially every month. Okay, because I believe it'll be a sign at the time it starts to recover that you are coming back, okay, to yourself again.
Yeah, right now I think I came back as a 14.
Okay, well, and I do essentially, and with a monthly test too.
Okay.
And I would add to what Jim said, be very, very patient about the time it takes to come back. It takes a long time, especially for people who have been on it for a long time.
Amen, John.
There was a guy at GU ASCO that put up a table on this, put up a slide, and it had initial testosterone, length of time on it, blah blah blah, all this stuff. But the lengths of time were unbelievably long. So be patient.
Well,
I'm gonna.
John, what he's got going in his favor, Mark does, is he's only 57,
Yeah,
relatively young. So you might see that T level come bouncing back pretty sooner than you think.
good
Thank you.
point.
I can let me just add real quick. I was only on I'm on the holiday after a year, but I was on the Orgovyx and abiraterone, and obviously, like what it did, it took me all the way down to nothing. At my 9-month checkpoint, my testosterone is at 366.
Yeah,
So
good.
Orgovyx supposedly will bring you back quicker, even if you're an old guy like me.
Pushing on, I've got Al Latimer next.
Hi. One point on the previous discussion, I was on Lupron for 10 years, and it started when I was 47, and at 57 I tried intermittent, just like where you are now, Mark, and my testosterone came back with a vengeance at that point, but so did my PSA, so I didn't have much of a holiday from it. Because my PSA started rising pretty rapidly at that point. So I went back on the Lupron, dropped the PSA back down to undetectable again. And I tried it a couple more times, but I never really had a holiday from the Lupron because the PSA just kept coming back immediately, even after 10 years of undetectable. 1 month later, 1 month later, it was detectable again, and so. But I was getting monthly, like the others were saying, I was getting monthly PSA tests and testosterone tests also. So it was followed quite closely. My thing now is I've had 6 Taxotere treatments, and tomorrow I'm going to have number 7. My PSA when I started this was 66, and after number 5, it was down to 12, and it's been going down each time. So that's all been good. And I think the doctor wants to keep the pedal to the metal as long as my PSA keeps going down. So my question now is, I'm kind of on this long term, and I seem to be surviving the short term side effects, but I'm wondering what things I should be looking for now that I'm doing this more long term. Things I should be asking the doctor, things I should be watching out for. I know some of you have been doing this longer than 6 treatments. And this treatment tomorrow will be number 7 for me. So that's my
And you
question.
said you got your PSA is now down to, did you say 7?
It's down to 12.
12.
Well, that was 3 weeks ago. I'll have another PSA test tomorrow to see what it is now. But that was after, well, that was after treatment number 5, because I won't know the results from treatment number 6 until tomorrow.
Well, who's done long term? Anyone done longer term docetaxel on the call? Who's done a bunch of docetaxels? We today, of course, we don't have Ken Anderson on here, who's the king. But anyone else? Anyone else done lots of docetaxel?
Well,
Well,
then I'll keep you posted.
Okay, he'll be
well, no,
keeping.
I think we can, we like to get the peer, we like to get the peer response first out. But, we can tell you, us as moderators, what we've observed. Peter, unfortunately, just had to leave off because I think he would have had some input on this. The biggest concern and what you've really got to keep a very, very close eye on are your blood counts. I'll let Dr. John say a little more on that. But if you tolerate it well, which you seem to be doing, and you keep your hair as you seem to be doing, and God bless you. Yeah, I mean, we know people that have. I had a friend many years ago who I think he did around 40 at the time.
Wow. Wow.
And you just and it kept his PSA low for the longest time, and he didn't feel. He managed the fatigue, he exercised, he managed the diet and everything else. But I think the biggest issue that can creep up on you, and of course, Dr. Belusic should be watching over this, is your blood counts, because if you let the docetaxel drive your blood counts too low, it can be tough to come back from that. I don't know, Dr. John, would you want to comment on that?
Yeah, absolutely. You'll be vulnerable to more problems. But how often is he doing your white counts and
Oh,
red counts? And
every time I go in for a treatment, the routine is first they draw blood, and they process it right there.
okay,
I see the doctor after that, and they have the results right then and there. And my blood work has been steady. I haven't seen any issues with it. They haven't seen any issues with it. But so yes, they are watching the blood count quite closely.
excellent.
Quick question. Do they check your blood count 1 week out as well?
They do not.
Okay. You might want to start asking about that because I did 6 rounds of docetaxel and did great through the 5. And after the 6th, my 1 week out, and I took Neulasta or something similar. But after the 6th, for whatever reason, my white count didn't come back. And now I'm at 5 months and I'm starting to get near normal. So you might want to just, and that's something my doctor said, they wanted to see 1 week out and then right before they do the next infusion. So you might ask about that.
So you only did
Al,
6? Yes.
yeah, this is Len. I would say the other thing to keep an eye on is signs of peripheral neuropathy, because it's very stubborn to any kind of treatment for the neuropathy, and it could really kind of wreck your quality of life. So,
Um,
don't try
I
and
do
push
have
that too far.
I
Sorry?
do have a little bit of neuropathy. It does seem to be increasing a little bit. Um, I don't know what point it should become a concern. I do mention it to the doctor each time, and so far they haven't been concerned about it.
Okay. As long as it's on their radar
Well,
and yours.
yeah, and I think you have to be concerned about it as much as the doctor, because the doctor's going to keep pushing until you cry out. So watch it. The other thing that I get this from Peter originally, is that B6. We mentioned it to you before. You can take a lot of B6. You tell Belusic you want to take B6 for the neuropathy. You get it at the drugstore. It is a good supplement for people with neuropathy. It has worked pretty well for me. Um, so so consider taking B6, and see if
That's a
that helps you.
that's a prescription.
No,
No,
it's just a supplement that you get at the drugstore.
Okay, so it's over the counter.
CVS, Walgreens, B6. but be sure to tell Belusic that this is what you want to do. But when there's a bunch of us on here that have used it and have found it helpful, and to deal with neuropathy. So I would just want to put that on the table for you as one alternative. Herb, it looks like you wanted to say something.
No, I'm okay.
Okay.
Actually, why don't we just go for your turn now, Herb? Okay.
Okay, well, thank you, everybody. Appreciate that.
Let's
No,
just check. Let's just make sure no one else wants to talk to Al though before we go
yeah,
across. Yeah.
no. Let me go at the end. It's too long a saga.
Well, it may not be. That's for we'll let Dr. John decide that. But does anybody else have anything they want to say to Jim B? Go ahead.
Hi guys, joining you late here. But hey Rick, how long have you had your neuropathy?
Oh my gosh, since 2014, maybe 2000. The first it kicked in about 2 years after I stopped my hormone therapy. And I just suddenly had trouble in the cold weather walking, big trouble walking in the cold weather. It was that painful. I was just hobbling around. And I think probably have had it now 9 years, 8 or 9 years, but it's intermittent.
Right. And I'm 6 months out of chemotherapy and I have, continuous neuropathy without any relief. Nothing seems to give me relief. But it's not a short-term thing is what I'm understanding from other people's experiences and my own. So I would just like to make Al aware of that, that
So,
those sort of
so
side
Rick, you
effects.
have pain with your neuropathy?
I do
Yeah.
have
I,
nerve pain with my neuropathy in
I
my
don't,
feet.
I don't have any pain. It's just a little, it feels like a little tingling in a couple of the toes.
Well, don't let it get beyond that. Is my is my advice. You don't want to let it get too much beyond that because once it starts up, man, and with me, I think it's also compromised by the fact that I do have Raynaud's, and so the circulation is so bad, is really bad, and so when the cold weather comes between the Raynaud's and the neuropathy, it's painful, and but the B6 has definitely helped. And
Okay.
my neuropathy came from the hormone therapy. It wasn't from chemo. And it is
Well,
a
my,
known side effect. It's not that common, but it is a known side effect if you do long-term hormone therapy. I did 2.5 years, 3 years.
I didn't notice it with the hormone therapy, but I first noticed it when I was doing PLUVICTO. I started to notice something, and now now the tingling seems to be increasing a little.
Just just stay aware of it. Stay on top of it.
Okay.
You don't want the docetaxel to nail you. There's probably several guys on this call, not just Jim Barnes, who have um, minor neuropathy. Well, they may not think it's so minor, but they have some neuropathy from their chemotherapy left over. I know Peter definitely does. Peter Kafka definitely does. He's not here now, but we won't ask for a show of hands, but it's there.
So, Herb, I appreciate your willingness to go at the end in case we run out of time, but you are in the hospital and there is an awful lot going on. So, uh, I think I'd like to ask you to give us an update now, if you don't mind.
All right. Uh, the saga is multiple issues, not just prostate cancer. I came off of PLUVICTO beginning of January, and my PSA is still pretty low. So that is in check. But I had spinal surgery, spinal fusion surgery. And after my spinal fusion surgery, something went haywire with my serum potassium. And it turns out that serum potassium is controlled by cortisol, and cortisol is controlled by adrenocorticotropic hormone. And then they found out that I have sky high levels of ACTH and then high levels of cortisol, which led to this low potassium. And so that's why I'm in the hospital, to try to track down why I have what is Cushing's syndrome. And so they're giving me a whole bunch of tests. They do not think it is related to prostate cancer. Right now, the presumptive diagnosis is that it's a de novo something, which, according to the latest information, high probability of being benign and resectable. But we don't know yet. So that I'm here at the NIH hospital just getting tested. I had scans today. I have scans tomorrow. I have up through Friday every day. I've got PET scan or CAT scan or various scan to localize this. So we have to just be hopeful, guys. I mean that it can be something they can treat. The other issue I want to bring up is very interesting.
Well,
I got my
hold on a
liver.
minute, Herb. Before we move on to the other issue, can we talk about this issue?
Sure. What would you want to ask your question?
Okay. Well, I was hoping John would ask, but
Okay. What we want is biopsies. We want to see what that thing is. That's
They will.
that's what Rick doesn't want to say because he's probably said it already to you, I think.
They said it
And
already, and I've talked to them about biopsies, and the biopsies will come after the imaging.
okay, and there's plenty of imaging this week.
Right.
so
They want to. I mean, NIH is trying to avoid biopsies. They want to do. They're trying to improve techniques for imaging. So
well,
I
I'm
am a
sure.
research patient.
Right. And I'm sure they are, but there are two issues that come to mind. First of all, they did biopsy the liver, right?
But that was at Sibley. That was elsewhere.
Okay. Did they do a biopsy on the lesion in your liver?
At Sibley Hospital, at Hopkins.
Right. Did they do, so the answer is yes. And when did they do
Sibley,
that?
they did that last week.
And do we have any results from that?
No.
Okay. When do you think we might get some results from that lesion?
Maybe, hopefully, the end of this week.
Okay. Now, they want to test their scanning, which of course is great, but we don't want Professor Herb to be the lab rat. So there are two questions that come to my mind. First of all, I don't know why, but they don't. I guess they want to leave the lung lesion in place so they can check and then they can see if it shows up with whatever new scanning they have. And then afterwards they can biopsy it and see if it confirms. I get that, except I don't necessarily think that personally that's in the best interest of the patient, but that's what they want to do. The second thing is, do they have or have they scheduled a gallium dotatate, a gallium-68
Yes, that's
dotatate
what
scan?
Wednesday.
So that's going to be on Wednesday.
Yes.
So that hopefully, if it works, and that I know is not is FDA approved, so they may be using that as part of something else that they're doing to compare some new scan that they have. But that gallium dotatate should show any neuroendocrine tumors, right?
Right. That's right. That's why they're doing it.
Okay. So hopefully we'll get some result on Wednesday as to what's there. And then I think it's your decision how long you want to play along with them versus getting a biopsy of the lung,
I mean,
because we need.
I think, Rick, if this gallium dotatate shows something, there's no doubt they're going to do the biopsy.
Hope so.
If
Now,
not a resection.
And that's scheduled as well. We talked about that today. We talked about my fitness for surgery today.
okay. Now, what about getting some hormone therapy meds into you other than Lupron
All
or
right. So
Eligard?
today we actually today I got ketoconazole.
Oh, wow.
But, yeah, but ketoconazole is from Oliver Scholem. It's from
Yeah, but it will knock down testosterone as well as cortisol.
it may, but it's why it should not be hard to get you a second line anti-androgen. Here's what's
You would
bothering me.
think.
Here's what's bothering me, and then you can respond. You are not even on standard of care, and they're putting you on standard of care for whatever their reasons are, and you should be at this point in time on either apalutamide or enzalutamide or darolutamide, all of which everybody else seems to be able to get. But because you're sitting there in the NIH, they're giving you ketoconazole, which we stopped doling out in 2008, because that's when they were testing. That's around the time they were testing enzalutamide, and people were getting enzalutamide instead of ketoconazole. I'm not saying ketoconazole doesn't work, but it's like giving you bicalutamide. And I feel like, you talk to your GU medonc at NIH, and she says, oh, well, we can't get enzalutamide, it's not in our formulary. Well, I don't care about their formulary, I care about herb. And we can't be keeping you off. I mean, it's a
Right.
joke to
Rick,
offer you ketoconazole, in my view.
I hear you. I hear you. Um, I agree. But the other part of it is there's something else weird going on. And I want to. I don't want to take up again. I'm embarrassed by it.
No, you got to talk to us about this because it's a huge issue. This is why I want you on a decent. This is why I want you on a decent second line anti-androgen. Tell the folks.
So, my last Lupron shot was February 12th, 3-month depot. At that time, I didn't notice, and they didn't notice, that my serum testosterone was 60. However, when I came into this hospital, my serum testosterone is near 100. Now, why the hell should serum testosterone be 100 when I had a Lupron shot a month ago? And I've been questioning them intently because I can't figure that one out. Because the oncologist said, well, maybe it didn't absorb. I don't actually believe that's so. That did not register with me. That doesn't seem a parsimonious explanation. But that's what testosterone is, and I've been questioning everybody, and nobody can give me an answer. Why, in the presence of dipolupron, should testosterone be high?
Because your pituitary
So that's another issue,
screwed up.
and that's another. No, but the pituitary, that route is a very crooked route. So
Well, there must be some LH
it's
in the system.
right now it's medically interesting, which is unfortunate.
Well, I mean, here's what I see, and Dr. John, I'd love you to comment, and Len. But we know that the way that the Lupron work, way that LHRH drugs work, is they act on the pituitary. That's
Right.
their path of their mechanism, right? Now, if you have a pituitary that isn't functioning right, which is quite likely given all this other stuff that we're talking about, we don't know why it isn't functioning right. It would also explain why the normal LHRH mechanism isn't functioning right and why you have testosterone as well as having in the light of Lupron. And it would also indicate we need to get a second line anti-androgen into you that will
Yes, I
protect
agree.
you, right?
Yes.
And
The other
and
issue
go ahead,
we do
John.
know, Rick. We also know the pituitary is not the source of ACTH.
Okay, but
They
we
measured
know
that today.
right, but that's fine. But we know the pituitary isn't right. Henry's saying, what about Orgovyx? It doesn't matter what the LHRH is. At this point, he's been on Eligard or Lupron for long enough that it doesn't matter if it's an agonist or an antagonist. The problem is he's not responding to that LHRH drug, Henry. And
Well, there
we
must
don't
be
know
a
why. But whilst we're figuring out why, we should be protecting
Yeah.
him by him taking an anti-androgen. So same as the guys who are on monotherapy. The guys who are on monotherapy, apalutamide, enzalutamide, darolutamide, they don't take an LHRH, but it protects them. And what are we giving Herb? Ketoconazole. Hello?
Well, for
Hey, Herb, is there any chance that
yes,
maybe when they gave you the last Lupron shot that they didn't mix it well? I mean,
potentially.
I had to have mine done at home due to insurance, and I watched the nurse, and it took her a while to get this thing mixed, and she's like, this is always a really tough drug to get mixed through. So, if it's a drug that
Maybe
maybe,
that's well, but the reason I say that not is because it was already high at the time of the last Lupron shot.
that's a good point. Just
So it's just very confusing. There's just too many different data points that don't agree with each
Lost
other.
audio. Or
Me?
So I got a question for you, Herb. The the adrenal glands produce cortisol, correct?
I lost my
Right.
sound. Anybody else?
So abiraterone suppresses testosterone from both testes and the adrenal
Adrenal.
glands, as you know. So
Right.
why not put you on Abby to see if that brings down the T levels?
Well, one reason is because the reason I was off Abby is because of my mutation in my receptor, which makes Abby an agonist rather than an antagonist.
Oh,
I have a, a, mut, a mutation in my testosterone receptor T78A, which makes it, which is contraindicated to Abby according to the FMI report.
right, right, okay.
So I am trying to get enzalutamide or darolutamide. I'm going to work on it even more tomorrow.
Yeah.
But you have to remember, my PSA is still pretty low and it's responding to PLUVICTO still. So
Yeah.
there's a little cushion.
Yeah.
But I agree with Rick. We should have something in place. This could be just because I'm being treated by two different hospitals, two different docs. They do talk to each other, but not as well as they should. And I'm in the middle.
So
Well,
the NIH doesn't have darolutamide on their formulary. What
No,
about
they will not.
so what
No.
about your other doctors? Can't they prescribe it even though you're at the
He
NIH
tried.
hospital?
He tried. At Hopkins, insurance turned us down for Dara.
Hmm.
You know, and I don't get that. Dr. John, you want to talk about Darrow a little bit? Because you
Well, it's
got
his
Darrow and
inpatient.
you were castrate resistant. They got it for you?
It's Herb's inpatient status that's the problem. So, I mean, it might be very easy to get a prescription, send it to Bayer, and have them give it to Herb for free. That's what happened with
No,
me.
they won't do that. They certainly
But
won't
they
do that.
won't, but he's an inpatient, and in inpatient status, you can't bring in any kind of outside anything. Um, I don't know if NIH is different because everybody's in there, having studies done, but that's generally the case in an inpatient hospital. What we'd have to do is go and get a non-formulary request through the pharmacy for a drug that's not on the formulary. It's not really that hard when you have a good reason for it. Well,
So there we go.
I have to move on. I only want to say that everybody
Go ahead.
wants you to
No, go ahead. I mean, I'll take any
everyone.
comments privately. I
Yeah,
appreciate everybody who sent greetings. I thank you. I really appreciate everybody's support. And hopefully
and it,
they're going to find out that this is a benign net that they can treat.
and the emotional pressure of all this is that we are really concerned about you, and we really want you to be pushing your treatment as best you can,
Mhm.
regardless of the specific details. I have more people left than I can fit into the amount of time. So be brief, and if we can't finish with what you need to talk about, we're going to just put you on to next week and remember who you are. Or
Yeah,
you can write to any of us moderators and ask your question if we don't get to you. But I got to
yeah. I
move
mean,
on.
John, I'm willing to go over time because if we put too many people off till next week, we get ourselves a problem. So let's see how we go. How many people stay on? Let's go through at least until quarter after the hour.
Okay,
I can
yeah.
if you need to drop off, I'm happy to continue
No, no,
moderating
no.
here.
I don't need to drop off. It's just that we hate to leave people off who've asked to speak.
Right,
I'm going to go
exactly.
to Terrell. I'm going to go to Terrell next, and then Jack. Terrell, are you
Oh,
still here?
I'm here. Yeah, I'll be brief. I'm in my 13th month of the intermittent hormone treatment from Lupron and abiraterone. I had blood today, and my PSA is undetectable, and the
Hey.
testosterone is 420 something. So I'm good, and I'm under my minute. Goodbye.
So you mean you're 13 months off of all meds now?
Yeah, yeah.
Great, 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 great. With an undetectable PSA. Boy, I hope that happens to me. I'm right at the
So
beginning of a
The,
trial
right,
here.
tes- the
How do you
testosterone.
feel?
right,
Oh, I feel great. I feel great.
Nah.
I always felt
yeah,
good.
and
I never really felt bad from the cancer, the abiraterone. I exercised a lot and I eat right, so it never really affected me. I got tired, but that was probably from the lack of testosterone, not the. But I felt great the whole time. So there's my minute.
the comment I want to make on that is for all of the guys who are considering IHT and the Mark Thompsons who are out there because it does work. And here we've got a guy 13 months out after coming off of it, and his testosterone is still, his PSA is still low, and his testosterone's come back. And Len has been just a poster boy on that. I had a guy write to me today, somebody who does some volunteering for us, and he's been on for 7 years on ADT. There's no real reason, and his doctor doesn't want to give him a holiday. Um, I just, I don't understand why we wouldn't encourage men. He feels that the results are adverse from taking a holiday. That's just not there, and I can't argue with this guy. but I do think that the evidence is out there that you can take these holidays. And Terrell's a perfect example. And I don't want to just brush over this. I want those of you thinking about a holiday to talk about it with your doc at the right time. I mean, we've got a bunch of people on here who are taking holidays right now and doing just fine. That's my
Rick, maybe you
soapbox.
could clarify this for me. The evidence is there, and we've seen it in many of our people, but is it all anecdotal evidence? Is there any experimental evidence that this is a good thing and a safe thing to do?
I'll throw that one at Len because he follows this follows this IHT literature better than I do. You're muted, Len.
Sorry about that. I was just entering something in the chat box about ketoconazole, which Herb already said, but I'm not sure everybody heard him. But anyway, so this question, Rick, is benefits of IHT versus risk.
Yes.
Yeah, and John's Dr. John is saying, is there any clinical evidence?
Is there any
that it's not
experimental
adverse?
evidence that it's safe to
To
do,
my
not just
knowledge,
anecdotal?
yeah, to my knowledge, there have been clinical trials, and I could probably shove it into the chat box, that intermittent hormonal therapy has been shown to be, in clinical trials, has been shown to be non-inferior to continuous ADT.
That's what I
Right.
was looking for. Thank you.
Yeah.
Jack, Dr. Jack, can you take it up?
Yeah, I'll be brief. I
Thank you.
got my PSMA scan. This is my third one. I had one Aximum and 3 PSMA scans. And all along, Dr. Carroll told me that it probably am avid. It just is not showing up until the PSA goes up. So my PSA went up to 1.7, maybe higher, by the time I had the test done last Friday, and the results came in late this afternoon. So I haven't spoken to anybody. I try to make an appointment with my radiation oncologist. It's not available till April 5th. But what it did show is that I am avid, and it did show what the Aximum showed in the subhilar region, which has been corroborated by biopsy. There is a metastatic deposit. And in addition, a new focal radiotracer uptake at the L4 pedicle in my spine and left ninth posterior lateral rib, concerning, quote unquote, for Usher's metastatic disease. Concerning, I don't know if that means definite, but obviously it's in more than one spot. So the issue for me is to go on ADT as soon as possible. However, I've got atrial fib that's come along over the past 2 months, recurrent after having had an ablation 10 years ago. And I guess the anxiety of torturing myself with all kinds of fear, added to the adrenaline and everything else that got the atrial fib going. And I'm taking a pretty heavy duty antiarrhythmic drug called Multac and blood thinners. So I'm going to try and get up to New York and get another ablation because you can't really take Multac and androgen deprivation therapy without being very closely monitored for QT elongation and on the EKG, and putting me at risk for a bad cardiac result. I'm scheduled to have a cardiac stress echo next week, hopefully, if they can squeeze me in with my internist to determine whether or not I've got any cardiovascular disease that could be driving this atrial fib. Because in the patch that I had done on my 2-week patch, Zeo patch, to monitor me, it showed for the first time a run of ventricular tachycardia, which could be a harbinger of bad disease. So I'm hoping that it's not, but if it is, I'll have to deal with it. So it's complicated because I can't get on the ADT as much as I recognize the necessity. because of this other drug that I'm on. So I'm going to see, hopefully, if I don't have major vascular disease in my heart, I can get up to New York and get ablated rather than have it done down here because I trust Dr. Reddy and he's quite good,
So,
and maybe I can get myself ablated so I can go on ADT as soon as possible.
so Jack,
Yeah.
when you say you can't go on ADT, we understand the risks of the LHRH, but what about monotherapy? What about going on a monotherapy second line anti-androgen?
Well, I'm talking in general. Any of those are not compatible second line, first line with Motec. You can look it up. It's it's very risky, and I'm not a kid, so I'm more vulnerable to cardiac arrhythmias since I've had them in the past. So
Okay, so
I
you're saying that the anti-androgen, the ARI, the androgen receptor inhibitors, the abiraterone, the LHRH drugs all have different actions, and they all interfere with this drug.
well, I haven't run them down one at a time, and maybe they don't. So I'll have to look more closely
Okay,
at
so
that.
that's really what I'm asking you to do. What I'm
Sure.
saying is I get that the anti-androgen that the LHRH is a problem, but take a look at the second line anti-androgens, abiraterone, enzalutamide, apalutamide, darolutamide, and see, because maybe the alternative is you go on one of those monotherapy until you get your heart issue resolved.
It's a
Dr.
good point.
John, you know a little bit about this.
Darolutamide is not listed as an interaction with
Motec.
Maltec. There may be some wiggle room, Jack.
Maybe what?
There may be some wiggle room here. I mean, if the H2, if the testosterone blockers don't cause QT problems, you may be able to tolerate darolutamide
If they
better.
were to give it in lieu of
Yeah,
Ornavix.
in lieu of, without the Lupron.
I actually mentioned that to Belusic, and he shook his head as if, like he hasn't done that before.
No, I'm
Maybe
sure he hasn't. Maybe he's afraid to do it.
by itself. But I haven't spoken to him. I have to set up an appointment with him tomorrow, and I also may go talk to the people in New York. My medical oncologist up there also, who I'm not crazy about, but we'll see what happens with Danila, what he has to say.
Okay.
I've lost a certain amount of confidence because so many people have been told me I should have gotten IMRT plus ADT from the outset, and now we look at my pelvic bed, and my prostate bed, and nothing has shown up with any of my scans. So it's gone right to the lung, lymph node, and the bone, and I'm thinking of what I would have gone through if I listened to them and but it's not only not listening, it's also going along with Carol said, let's go along and let's see what else shows up. So we sort of hesitated, and I by now I could have gone through a whole course of IMRT and ADT.
Yeah.
To what end? I mean, just to burn my guts and my bladder and everything else. So it's kind of scary, how this disease operates. And
What
Well,
about
Rube,
focal radiation on the lesions?
well, I have to speak to the radiation oncologist. I was wondering about protons, and the reason I asked that, I know it hasn't been documented as affected, but it's near the heart. It's on the left side and the left rib, left ninth rib, and to go, SBRT is like a bullet. It goes right through you, and it doesn't stop at the lesion. And protons, they go right to the lesion. It doesn't go through it like a bullet, and there's something very appealing about that. And but the question is, a lot of people don't believe in protons' efficacy as much as they do in CyberKnife, SBRT. So I'm going to have to maybe speak to both a proton and a radiation oncologist who understands both modalities, because I wonder about that. Because has anybody had proton pencil beam radiation in this group?
Well, Peter
Yes,
has.
I have.
Go
And
Who
ahead,
was that?
Jerry.
This is Jerry. That's how we did ablated my prostate and the prostate bed. We did proton, and for the exact reason that you just said, I didn't want X-ray going all the way through my body. And I tell you, that was almost 4.5 years ago. So everything's been fine.
I have some
And
friends. Yeah. But
and just
what about spot radiation for focal metastases?
I'm
Is that,
sorry, what kind?
just spot radiation,
Well,
focal to
well, we
metastatic
know that that has a good clinical
with proton?
effect.
Well,
Oh, with proton. Oh, sorry.
I've had I've had I haven't had it. I wanted spot radiation with proton, and Mayo said they will not do it under spot radiation. So I had to give in and have X-ray.
I see.
That's Mayo or in Phoenix, but I don't know about the East Coast, or
Well,
you just have to ask.
well, when I was in Rochester 4 years ago, and he was all for that. Quan, he really believed in going spot radiation with proton pencil beam. He was talking that up quite a bit.
Yeah, Jack, talk to Peter. Talk to Peter Kafka. He had spot treatment with pencil beam proton.
Where's Peter? He's gone.
Yeah, he's not here now.
I'll talk
Yeah,
next week.
Jack, there's also Cal Proton down in San Diego, Dr. Rizzo. You might give him a call.
Russo. Yeah, that's where Peter went.
Yeah, down in Cal Proton down in San Diego. He's very approachable, very nice guy.
Yeah, I don't think he's in San Diego anymore. He's shifted because Peter just mentioned that to us a couple of days ago.
Oh, I'm sorry to hear that.
So, but Russo is the right guy, is a guy to talk to. But again, you can drive yourself crazy by talking to so many docs. Dealing with somebody who's doing that right now, and so you got to be careful.
Yeah.
And you've
Well,
got, and I would talk to somebody who doesn't have a hat in the ring
it's
or
very hard.
a horse in the race. I mean, if you talk to Russo, he's going to tell you he can do it,
All the
and so
proton guys say they can do it because they do have so much,
talk to somebody who's more agnostic would be my recommendation.
that makes sense. Thank you.
It's
I
7
just put
o'clock.
Peter's email in the chat window for you, Dr. Jack.
Thank you.
It's 7 o'clock. Leave if you have to. Rick has given us the okay to continue for 15 minutes more. So, how about Philip? What have you got on your mind today, Philip?
I apologize if I'm in the wrong group. I appreciate y'all very much. I was diagnosed with PC when I was 50 years old, 50. I had robotic surgery at MD Anderson in Houston a little over 5 years ago. I have not been treated with anything else, just the surgery. And what's been happening is about 30 months after surgery, I did an ultra sensitive PSA. MD Anderson did not ask me to do that. I just did it on my own. And the I got a reading. At the lowest, it was 0.028, and today it's a 0.090. So I just want to prepare myself for a future decision. My current urologist here in Austin says that the option that has a chance for a cure is radiation. I'm not crazy about radiation because it took it created a new cancer in my dad. Um, his life was extended 13 years, but year 14, um, what presented itself was a new type of cancer that was created by the radiation. So I just would like to get some guidance on what kind of homework I should be doing. One of the things I'm thinking in my mind is some exceptional scanning, uh, followed by surgery. Try to maybe kind of like do a precision surgery. I don't know if anybody's ever tried that. And then I'm I'm uneducated here, but I'm wondering if before they um, zap your prostate bed, do they do scanning, exceptional scanning first to make sure that the cancer is there before they scan the
Okay,
prostate? I mean, before they zap it.
let me hold you up, Philip. A couple of things. I'm looking and I have a note that your PSA was at 0.096 last January.
Yes, sir. And so what
And
it did,
it's
it fell.
right. And now it's at 0.090 a year later,
Yes, sir.
14 months later, right?
Yes, sir.
So I think that given that it's barely moved, maybe it fell, maybe it went up, but you have to understand these tests to 3 decimal places are not that reliable. They vary.
Okay.
This is not like your PSA going from 9.6 down to 6 point something and then back up to 9.0. There is lots and lots of variation. So I wouldn't be too concerned. I think you're doing exactly the right thing, which is keep watching it. How often do you get tested?
Every 3 months.
So I would keep getting tested. Who is the I hope it's not the urologist that we had in the reminder this week, because he's
His
in
name is
Austin. I know he's in Austin.
yeah. What's his name is Dr. Christopher Yang
Okay.
with
Okay.
NAU, North Austin Urology.
Okay, because we featured a guy in Austin who's a urologist called Dr. Dick Chop, and
Right.
we wouldn't want you seeing Dr. Dick Chop. But that said, I think that you're getting ahead of yourself,
Okay.
because until with recurrence like this, I mean, you had your surgery back in 2016. What we generally will suggest that people discuss with their doctors is allowing the PSA to rise to somewhere above 0.2, 0.2.
Okay.
And you right now are at 0.09. So you've got a long way to go, a really long way to go. And if
Okay,
your
sir.
PSA has barely moved, if anything, it's gone down over a year, then you're
It did.
doing all the right things. And to talk to you about, well, can they do this? Can they do that? I mean, I will tell you, yes, if they saw a metastasis in your lymph nodes, they could remove it with a lymphadenectomy, which we have seen, lymphadenectomy, which we have had seen guys do, but they're never successful. They're
Okay.
never successful. I mean, the number of guys we've seen go through lymphadenectomies and then later on they have to come back for radiation is enormous. And I'm sure, I shouldn't say they're never successful. They may possibly be successful for a few, but it is a procedure that Mayo recommended to many, many guys, and we've seen too many where it didn't work. So, we would be saying, look into it, get the results when you go out there. But Philip, right now, I think there's a lot of guys who'd like to be 7 years out and a PSA of 0.09. I mean, the possibility is they left some healthy tissue in there.
Hmm. Interesting. Well, I appreciate your time very much. Part of the advice or food for thought was that I was given was At some point, the earlier you radiate, the better your chances the of a cure. I don't know if that's
Yep.
accurate or not.
Well, it is and it isn't. We now know that it doesn't make a lot of difference if you radiate between um, 2 months out and 8 months out or 9 months out. But once you get to where you are, it's not going to make that difference whether they do it 8 years out or 10 years out. I don't think that anybody's ever looked at that. So, yes, we have to be careful what we rely on and what we hear. And it is true. But that's true when we talk about the recurrence happening right away. In your case, we don't even know if it's recurrent.
Like I said, I appreciate y'all very much.
Also, I mean, it's implied in what Rick said, but just to make sure you know that the scans are not sensitive enough to pick anything up when the PSA is 0.09. So you couldn't even scan now and aim at anything. You wouldn't find out anything.
I was thinking scanning around the 0.2
Yeah.
time frame. I just wanted to prepare myself with information.
Yeah. I think that would be good, but I think it might take quite a while to get to 0.02 at the rate you're going.
I just want to add, Philip,
yes,
that your father's experience with radiation obviously makes you shy about it. But just remember, today's radiation is not your father's radiation. And what they're capable of doing now is incredible. So if it gets to the point where you need something, don't reject radiation.
Thank you, Mark.
Good point.
Great point, Mark.
Jim in Tucson, are you still on the line? That's not Jim Barnes. I guess the other Jim has signed out. Okay. How about Rich? You had a cat. Rich, are you still on the line?
No, I think he left.
Okay. Henry, you are you still here?
I am.
You kindly offered to wait until next week when your lab tests come back, but we do have a minute now if you want to start us off on what was on your mind.
I would like to take my minute to thank y'all for everything you do and to tell y'all to have a good night. Seriously. Thanks. Y'all work your tails off for us. Thank you so very much.
Thank you very much. Is there anybody else that would like to raise anything on their minds before we close?
Yeah, I got to ask Henry. Do you have your money on Alabama for the big dance? Because we're crying in our soup. We're crying in our soup in Tucson. We're crying big time in our soup here in Tucson. But maybe down in New Orleans, where you are in Alabama, it's another story, man. Hey.
It's all good. I'm just waiting on baseball season to start. Hey, y'all are the best. Thank y'all so much, really, for everything y'all do. I was going to send a message through the chat. Y'all really give so much to us, and I mean, it's a huge sacrifice. So thank you for everything y'all do.
No, it's not. I want you to know I can only speak for myself, but I think the other moderators feel the same way. I hope they do. This is not a sacrifice. This is a labor of love, which is a different thing to a sacrifice. But
and rewarding too.
And when we can make a difference, it means the world. And I mean, just even tonight, getting Dr. Jack to think about looking at some of these other drugs that he might be able to take. I mean, that's why we're here. We don't know. We're not the docs, but we're here to put ideas into people's heads that they can follow through that may reduce their anxiety. That's really what we're about. And I just want to tell you, all of you, just a reminder again about the webinar, which I did just put in there if you scroll up and if you haven't registered. But I got a beautiful message from the Maguires, which we will include in next week's reminder. I won't say more than that, but it's special. I mean, sometimes we are making a difference, and sometimes we made a difference. And when we made a difference and it was appreciated, that's for us. That's why we do what we do.
Well, y'all do make a difference. I mean, this all started almost 2 years ago now for me, and my wife is still stuffing broccoli down my face, and 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 broccoli sprouts. And Professor Herb,
Yes, sir.
I have not been on this in this group as long as you have, but buddy, everybody cares about you, and it you can feel it through the wires, so to speak. And I mean, we're all just concerned about you, buddy.
Thanks, Henry. And I know it. I feel it, and I'm getting all the good vibes. And I'm trying to. I want to survive this. I want to get through this. So I'm pushing.
That's
One
my
step,
man.
one step at a time, baby. Embrace the
Right.
suck.
Every day, every day I'm pushing. I don't want to leave you guys. You're my men.
We
Thank
love
you,
you.
everyone, for coming. And
Thank
we'll see
you.
Have a
you
good
next
night,
week.
everybody.
Hey, one quick
Good night.
thing. Nobody asked
Yes, Jeff.
Joseph if he had genetic testing, did they?
I asked him, and he never
Oh,
had any genetic testing.
well, how about Promise? Did he get the link to Promise so he could get free genetic
Yeah,
testing?
somebody gave me the link. Thank you.
Oh, great. I didn't hear that. I just wondered. Sorry.
Yeah. And
Right.
Joseph, it's a great point. It was on my mind. Thank you, Jeff Marchi. I do think that you should be talking to your lady Catalia about some somatic genetic testing. Remind me again where your PSA is.
1.02.
Yeah, it may be a little too low for blood. And if they can get anything off of the metastasis in the hip, if it's there, but the somatic is to see if there's anything special that your body is making rather than what you inherited. And but just have a general discussion, and the Promise is a great idea. It doesn't cost you anything, and it is really important, and it is standard of care, so it should have been done already. At least certainly the germline, the inherited, should have been done already.
Hey, Joseph, this is Henry, and I didn't want to take up our time earlier, but since we're a little bit over, I wanted to tell you that thanks to this group, I learned about somatic testing and learned about the two genetic mutations that I have, which are PTEN and SPOP, which are kind of a challenge to deal with. But I want to go back to the ADT. I'm 55, and the ADT, thanks to this group, I didn't fear it as much as maybe you are. I'm a young dude, and it's been so worth it. I take Effexor every day and just walk, and it's probably kept me alive because I'm a Gleason 9, positive margins, 8 out of 27 positive nodes, extraprosthetic extension, perineural invasion, every single bad pathological feature you can think of. And I would encourage you to, I'm sorry for giving you free advice, but I would encourage you to take a look at that. I've not had an erection for over 18 months now, but I'm alive, baby. And I got this awesome dog right beside me, and I've got my wife and my daughter. So thanks a lot.
Right.
Sorry, I apologize for wasting time
No,
at the
you
end.
don't. No apologies. That's
All right.
why we have you. And I would add, he's got a very pretty wife as well. And
Thank you.
so
Say, she loves you. Your accent is. I need to keep. I'm not going to get you two together virtual anymore. It'd be a problem for me.
but that's why we have these groups. This is what we want you to hear, Joseph. And you got to put it into the decision making function and decide where you want to go. I mean, I just get very scared when they've got distant Mets and they put them off. Because if you've got distant Mets, it's in your system. You can't reverse it once it's in the system. We can control it, but we can't take it out. We can't cure it. And so we know you've got distant Mets, and that's why we wanted to get you on, nail it for a while, and then come off on this intermittent that a lot of these guys are doing. So
could I ask you a point of clarification? I understand about going to Promise to get the genetic testing.
Yes.
Was there something else I should get from my doctor?
Yeah, you want to talk to her about somatic testing.
Somatic?
SOMATIC, somatic testing.
Your tissue from your prostatectomy is probably still available somewhere.
That's what I would bet. Yeah.
And get it off of that.
Okay.
Excuse me, guys. I would like to ask Joseph a question. Are you a veteran?
No.
Oh, okay. Any of you vets attend our veteran group, please. I think it's going to be this Thursday.
Correct. All right, guys.
Good night, everyone.
Thank you. Great job, Dr. John, standing in for Herb. And thank you, everybody. And we'll see you next week with Len.
Onwards and upwards.
Thank you.
Thank you.
Onwards and upwards.
Good night.
Good night, everybody.
Good night, everybody. Thank you, John.
Good night, everybody.
Good night.